Three, two,
Yes.
1. So we are live now. We can start our session. So over to you. Sir, you can start the session, sir.
Okay. I have to self-introduce myself.
Yes, sir.
Honorable friends, I am Dr. Sudhir Chandra, Associate Professor in Department of Medicine. And today evening, we will be talking about SGLT2 inhibitor and DPP4 inhibitor combination, glucocentric and holistic benefit, empagliflozin and Linagliptin combination in focus. Now we all know that type 2 diabetes mellitus has got multiple pathophysiological defects. We also know that this is the chronic stage of hyperglycemia associated with multiple complications. So we always look for a molecule which can help us in controlling hyperglycemia as well as in controlling different complications. Against this perspective and against the perspective that type 2 diabetes mellitus, a chronic progressive disease having multiple complications and multiple pathophysiological effects, what are the benefits of SGLT2 inhibition and DPP4 combination, glucocentric and holistic benefit? Friends, today the whole world is facing the tsunami of type 2 diabetes mellitus. And it is mostly affecting those countries which have got middle and lower level of income. In 2000, the global estimate of adults living with diabetes was 151 million. By 2009, it has grown to 285 million. In 9 years, 88% increase from 151 million to 285 million, a staggering 88% growth. And today, 9.3% of adults aged 20 to 79 years, a staggering 463 million people are living with diabetes. A decade ago in 2010, the global projection of diabetes in 2015-25 was 438 million. What we projected in 2010, that by 2015, the figure of diabetics in the world will be 438 million. And what is happening? What has happened? With still 5 years to go, that prediction has already been surpassed by 25 million. Friends, type 2 diabetes is a complex disease. Type 2 diabetes has got chronic hyperglycemia, which gradually increases over time because it is a relentlessly progressive disease associated with gradual but persistent decline of beta cells. Cardiovascular disease is the major cause of premature death in type 2 diabetes, with 70 to 75% of deaths may be attributable to CV complications. So this is an amazing finding that 70 to 75% of the deaths in type 2 diabetes is associated with cardiovascular complications. Atherosclerotic disease becomes a very important entity. And atherosclerotic cardiovascular disease is known to occur nearly 14.6 years earlier. 14.6 years earlier in the presence of type 2 diabetes. The risk of heart failure is increased by 2.5 to 5-fold in type 2 diabetes mellitus. And friends, heart failure is the second commonest manifestation of diabetic cardiomyopathy and may also present very early in the course of disease. Framingham offspring study findings suggest that two-thirds of the patients of diabetes mellitus have subclinical cardiovascular disease. Diabetes mellitus increases the risk of subclinical cardiovascular disease by 4.3-fold. So we have many unmet clinical needs in type 2 diabetes mellitus. Number one, increasing prevalence of type 2 diabetes. Rising prevalence of type 2 diabetes mellitus. We have already discussed how the number of cases rising is outscoring the predictions. You can see within your neighborhood how the people turning diabetic are increasing day by day. Second unmet need is difficult to achieve and maintain glycemic target. We have got significant number of type 2 diabetic patients who have got poor glycemic control in India. We know that glycemic control tends to decline over time with monotherapy. So this is a major challenge because if glycemia is not controlled, glucose is not controlled, complications will come. So risk of complication is the third unmet clinical need. With poor control, the risk of complications increase. South Asian phenotype, unfortunately, South Asian phenotype includes Indian also. South Indian phenotypes, unfortunately, predisposed to early macrovascular and microvascular complications of type 2 diabetes mellitus. High cost of not treating type 2 diabetes early is another important unmet clinical needs, which increases the indirect cost of treating type 2 diabetes mellitus. Indirect cost of complications is much higher than the direct cost of therapy. Whenever a patient says that a particular molecule which I prescribe to him is a very important one and the patient says that the cost is high, I tell him the treatment of diabetes mellitus is not so costly. The treatment of complications is. Suppose a patient of type 2 diabetes mellitus needs a CABG, requiring an expenditure of 5 lakh in a good hospital, with whole family putting their time for him. What is the cost? What is the socio-economic pressure? Similarly, if a patient develops CKD, type 2 diabetes mellitus, there is need for twice or thrice hemodialysis and maybe renal transplantation. Just calculate the cost. So cost of treating diabetes is not so much. Cost of treating complication is, and that is another and very important unmet clinical need. Now, dysglycemic legacy. We all know about the metabolic memory or the legacy effect. When we control glucose early, the benefits are seen later on. You control glucose intensely and early, and the benefits are seen later on, even if glucose control is not so adequately done. Similarly, the dysglycemic legacy is just reverse of that. Poor glycosylated hemoglobin control in first year of diagnosis and face increased long-term severe risk later on. In this graph, you can see the black dotted line representing patients with glycosylated hemoglobin, more than 7% of glycosylated hemoglobin, who have not received intensive therapy. IT means intensive therapy within 1 year. And what does the blue line suggest? Patients with intense therapy who have got glycosylated hemoglobin below 7 in the first year of diagnosis. What happens after 5.3 years? You just see, friends, what the intensive control and putting glycosylated hemoglobin below 7 at the end of 5.3 years in this study means. significantly increased risk of MI 67%, stroke 51% increase, heart failure 64% increase, and composite CVE increase in 62%. So maintaining glycemic targets with monotherapy can be difficult to achieve. Often there is a tendency, and there was advocacy, that you start with one molecule, gradually add another, whatever may be the glycosylated hemoglobin, but that strategy is not going to work. It has been shown clearly in UKPDS that glycemic control tends to decline over time with monotherapy. 4,075 patients with type 2 diabetes were randomized to diet alone, insulin, sulfonylurea, or metformin for 9 years. On the left side, you can see the graph of adequately controlled metformin who were followed at 3 years, 6 years, and 9 years. At 0 level, they were adequately controlled. At the end of 3 years, only 44% remained adequately controlled. At 6 years, 34%, and at 9 years, only 13% remained adequately controlled. So deterioration is there, marked deterioration. On the right side, we can see adequately controlled patients on sulfonylureas who at the end of 3, 6, and 9 years becomes respectively 50% of them are controlled, 34% and 24%. So maintaining glycemic targets with monotherapy can be very difficult to achieve. So this is the earlier use of combination therapy treating to target compared with conventional therapy. In the gray line, faint gray line represents the earlier adopted stepwise therapy. What was the stepwise therapy? Ask the patient to do diet and exercise, wait for 2 to 3 months, and then if the sugar control is not there, add monotherapy. Then after 3 months, if the combination therapy doesn't work, add the second combination, second drug. Then after a certain period, you up titrate if the glycemic control is not there. Even then, if glycemic control is not there, basal insulin is added to oral anti-diabetic agents. And ultimately, multiple daily injections are added. And what this did do? The patients was exposed to hyperglycemia for a long period. And what this prolonged hyperglycemia did to the patient? Predisposed the patient to the complications which are so dreadful, so costly to treat, and puts such a huge socio-economic burden on the society. And what does this blue line? See this blue line. Now, the authorities are recommending, strongly recommending, stressing the earlier use of combination therapy, which may improve treating to target compared with conventional therapy. This blue line, you can see how this glycosylated hemoglobin has been reduced. And naturally, when glycosylated hemoglobin has been reduced, the complications will be delayed, will be slowed down, if not halted altogether. So this is a very important picture showing the need and importance of earlier use of combination therapy as compared to the age-old, previously recommended as stepwise therapy. This is very important milestone development in the history of type 2 diabetes mellitus. From the triumvirate to the Ominous Octet, a new paradigm for the treatment of type 2 diabetes mellitus. This is from Ralph A. DiFranco, a milestone Banting lecture, and it was in Diabetes magazine, April 2009, volume 58. And what this was suggested? This suggested that prior to this lecture, we believed that triumvirate was the important factor. Triumvirate means 3. So what were the 3 powerful elements to control this type 2 diabetes mellitus? One was muscle factor, liver factor, and beta cell factor. And what did Dr. Ralph A. DiFranco suggested? He suggested the concept of Ominous Octet. 8 factors responsible for the pathophysiology of type 2 diabetes mellitus. The 8 factors were alpha cells, beta cells, liver, adipocytes, neurotransmitters, then kidneys, incretins, and muscles. So what was the inference? Inference was that type 2 diabetes mellitus was having multiple pathophysiological defects. So what we should do? We should use multiple drugs used in combination to correct multiple pathophysiological defects. And this treatment should be based on known pathological abnormalities and not simply on the reduction of glycosylated hemoglobin. This thing, because pathophysiological factors are too many, preferably the molecules should address to the pathological abnormalities present in that particular patient. And therapy should be started early in the natural history of type 2 diabetes mellitus to prevent progressive beta cell failure, to give the patient benefit of the legacy effect or the metabolic memory, which we so often talk about. So what is the lesson? Lesson is hit early, hit hard. Now this is the ominous octet which we're talking about. And what happens when SGLT2 inhibitor and DPP4 inhibitors are combined together? This is the 360-degree holistic approach to combat the ominous octet responsible for the pathophysiology of type 2 diabetes mellitus. DPP4 inhibitor is having the unique action on alpha cells blocking glucagon secretion. Incretin effect is there, hepatic glucose production is lessened, and insulin secretion is glucose dependent secretagogue. Sulfonylurea is also a secretagogue, but that is not glucose dependent. If glucose is 90 and if you give a patient sulfonylurea, what will happen? The patient will go to hypoglycemia. But what happens with DPP4 inhibitor? If glucose is high, then its secretagogue action will be on the pancreas. If the sugar is 60, it will not decrease it. That is the beauty of this molecule. Of course, this is when it is not combined with insulin or another secretagogue like this sulfonylurea. But when it is used alone, or it is used with other molecule which is not having hypoglycemic action like SGLT2 inhibitor, it is not going to cause hypoglycemia. That is the beauty of DPP4 inhibitor. And SGLT2 inhibitor also has got an indirect effect on this. And SGLT2 inhibitor is also not known to cause hypoglycemia. When used alone, it can cause hypoglycemia only when it is used with insulin and this secretagogues like sulfonylureas. And this SGLT2 inhibitor has got indirect action on the GI absorption, and its major action is on the kidney proximal convoluted tubule, a unique way altogether, an action which is independent of the pancreatic effect, independent of the insulin, the action of glucose in the proximal tubule by blocking this SGLT2. So the ultimate effect is that we are covering the most of this ominous octet. So against this knowledge, what is the evolving recommendation for initial therapy? As I told you, we were following the stepwise therapy, but recommendation for initial combination therapy is evolving gradually. American Diabetic Association, in Standards of Medical Care in Diabetes 2020, has defined the pharmacological approaches to the glycemic treatment. And the initial combination therapy has been advocated for more rapid attainment of glycemic goals. Friends, we know that the absolute effectiveness of most oral molecules rarely exceed 1%. If we are using one oral molecule, it is in very rare cases they are going to reduce glycosylated hemoglobin 0.1%. So if the goal to be achieved is more than 1.5 to 2% above the target, then we cannot control the glycemia with just one molecule, and we have to give combination together. And that is what American Diabetic Association is recommending in the evolving therapy. Moreover, it has written that moreover, since the absolute effectiveness of most oral molecules rarely exceed 1%, initial combination therapy should be considered in patients presenting with A1C level 1.5 to 2% above target. Suppose the patient comes to us with 9 glycosylated hemoglobin and our aim is 7. Can we achieve with a single oral molecule? No. So in these cases, we have to go for the combination therapy. This is what happens when two molecules with complementary mode of actions, when two molecules having effect on different sites are properly combined together. A proper combination of DPP-4 inhibitor and SGLT2 inhibitor, they have contrasting actions somewhere, and so they complement each other. DPP-4 inhibitor is insulin-dependent mechanism. SGLT2 inhibitor is a unique, novel mechanism which is absolutely independent of insulin. SGLT2 inhibitor is known to increase levels of glucagon. And DPP-4 inhibitor, what it does, overwhelms this action of increased glucagon by SGLT2 inhibitor. In fact, dominates the blocking of this glucagon. SGLT2 inhibitor and DPP-4 inhibitor. DPP-4 inhibitor is weight neutral, whereas SGLT2 inhibitor reduces weight and reduces BP as well. And they have got some common beneficial actions also, like GLP-1 levels are increased, fasting and plasma glucose are decreased, and there is minimal, no hypoglycemia. Just imagine the beauty of the combination. Two molecules you are using for lowering the glucose, and there is no hypoglycemia. Hypoglycemia still remains one of the major factors responsible for the death of patients. And so this is very important that these two combination of these two molecules are causing no hypoglycemia, or the hypoglycemia is minimal. ADA 2020 guidelines, glucose lowering mechanism, medication in type 2 diabetes mellitus. This is the overall approach. Advocated first line therapy is metformin and lifestyle modification, including weight management and physical activity. And if there are indicators of high risk or established atherosclerotic cardiovascular disease, CKD, or heart failure, then consider independently of baseline glycosylated hemoglobin or individualized glycosylated hemoglobin target. Friends, the recommendation is that irrespective of glycosylated hemoglobin target, if there is presence of indicators of high risk or established atherosclerotic cardiovascular disease, CKD, or heart failure, then we have to consider either of the two molecules, that is a SGLT2 inhibitor or GLP-1 receptor agonist. Now, if atherosclerotic cardiovascular disease predominates, then indicators of then in that case, preferably GLP-1 receptor agonist with proven cardiovascular disease benefit is used, and alternatively SGLT2 inhibitor with proven cardiovascular disease benefit is used. Condition is one, GFR should be adequate. As of now, there is no recommendation for using at the lower eGFR we know. Heart failure or CKD dominates, then what we are going to do, particularly if heart failure is having reduced ejection fraction, then the recommendation is SGLT2 with evidence of receiving heart failure, the hospitalization for heart failure. Alternatively, GLP-1 receptor agonist can be used. And SGLT2 inhibitor and DPP-4 inhibitor may be combined in eligible patients when glycosylated hemoglobin is 1.5 to 2% higher than individualized target. As I have already told, when our target is 1.5 to 2%, one molecule is not going to lower down our glycemic target. So in those cases, combination therapy has to be done. And ADA 2020 guidelines, they recommend that SGLT2 inhibitor and DPP-4 inhibitor can be combined in eligible patients. Now, ESC Guidelines 2019 on diabetes, pre-diabetes, and CVD. Diabetes, pre-diabetes, cardiovascular disease has gone one step further. SGLT2 monotherapy as first-line therapy in cardiovascular disease and type 2 diabetes patients. Yes, friends, you are listening correctly. SGLT2 monotherapy as first-line therapy in cardiovascular disease and type 2 diabetes patients, even ahead of metformin. This is the chart. Type 2 diabetes mellitus drug-naive patients. Drug-naive patients means patients who have not taken drugs, oral hypoglycemic drug. If they come to us, then in those cases, if there are features of atherosclerotic heart disease or high or very high risk factors present, then we can consider SGLT2 therapy or GLP-1 receptor monotherapy. This is entirely change of the previous recommendations, gross shifting from the previous recommendations. And if patients of type 2 diabetes mellitus on metformin is there and ASCVD or very high risk CV factors are present, then we have to go for SGLT2 inhibitor or GLP-1 receptor agonist. AACE 2020 guidelines suggest the use of SGLT2 inhibitors recommended independent of glycemic control at established or high atherosclerotic cardiovascular disease or CKD is there. This is again in favor of that. We all know previously we had the glucose-centric approach of the diabetologists, endocrinologists across the globe was to control the sugar, and we expected everything to be set right. But now we believe in the patient-centric approach. We now know that type 2 diabetes mellitus is not a glucose entity only. It has got the multiple factors associated with it. And so in 2018, you know that ADA and ESD, the two apex organizations, they came together with a patient-centric approach, and that is being followed since then. That whatever is the background of the patient, according to that, we have to decide the treatment. So if the patient is having the cardiovascular issue, if the patient is having atherosclerotic cardiovascular disease, heart failure factor, or the kidney factor, then in those cases, SGLT2 inhibitor or this GLP-1 receptor agonist is recommended. So there is significantly higher efficacy of EMPA and Lina, fixed dose combination over monotherapies. Empagliflozin and Linagliptin. Empagliflozin representing SGLT2 inhibitor, Linagliptin representing DPP-4 inhibitor. The higher efficacy of EMPA-Lina of monotherapies was even more. If it was less than 8, the reduction in glycosylated hemoglobin was more than 1. And when the baseline glycosylated hemoglobin was 8.1%, the reduction of glycosylated hemoglobin was up to 1.8 to 1.9% in both drug-naive and metformin background cases. And even at 8% baseline, only FDC arm could reach the target. And there was durability of the action and achieving the target. Significant body weight, systolic blood pressure, and diastolic BP reduction was the bonus. Along with the target achievement, we had the significant body weight reduction, systolic blood pressure was also reduced, and diastolic BP reduction was also reduced. And despite high efficacy, there was no increased risk of hypoglycemia with EMPA and Lina. The risk was minimal, or there was no hypoglycemia or minimal risk, mild hypoglycemia, except when they were used with insulin and secretagogues. Now, we all are bothered that if you give SGLT2 inhibitor, there will be glycosuria, there will be a lot of glucose in urine, and glucose is the nidus for infection. So genital tract infections will be a very important thing. We are scared of that. And the beauty of this combination is that inhibition of DPP4 enzyme present in some bacteria and fungi may lead to less infection. So if we combine these two, we are free of an important worry which we have when we use SGLT2 inhibitor. We are worried about certain side effects of SGLT2, of which genital tract infection is very important one. And here in this combination, inhibition of DPP4 enzyme, which is present in some bacteria and fungi by DPP4 inhibitor, is leading to less infection. The better safety outcomes with simultaneous SGLT2 and DPP4 inhibition as compared to sequential. Suppose we use SGLT2 DPP4 inhibitor together at the very outset, and in another group of the patient, we use this sequential combination, first SGLT2 inhibitor and then DPP4 inhibitor, or first DPP4 inhibitor, then SGLT2 inhibitor. And this study has suggested that there is better safety outcomes when simultaneously both molecules are used. Then came these CV outcome trials for SGLT2 inhibitor in diabetes. In 2015, EMPA-REG outcome of 7,034 patients, CANVAS 4,339 patients, 2019 declared TIMI for dapagliflozin, orthogliflozin trial 3,900 patients. So these trials, which started with the EMPA-REG trial of empagliflozin, they have brought a gross change in the treatment of type 2 diabetes mellitus. They have entirely changed the concept of treatment of type 2 diabetes mellitus. Empagliflozin CV outcome study, EMPA-REG outcome, in 7,020 patients with type 2 diabetes and CVD, EMPA reduced risk for 3-point MACE, CV death, hospitalization for heart failure, and composite of hospitalization for heart failure or CV death significantly versus placebo. See the reduction of these different parameters. 14% reduction in 3-point MACE, 38% reduction in cardiovascular death, 32% reduction in all-cause mortality, 35% reduction in heart failure hospitalization. And see, even more robust data coming from the kidney point, decrease in new onset or worsening nephropathy, 39%. What more do you want from a molecule like this? Improvement in CV outcomes with empagliflozin is independent of glycemic control. CV benefits of empagliflozin occurred consistently across the board, across the spectrum of all HbA1c subgroups, at lower HbA1c level, at higher HbA1c level. the cardiovascular benefits of empagliflozin was apparent. They were observed even when glycosylated hemoglobin was less than 7% at baseline. Hospitalization for heart failure outcomes from SGLT2 inhibitor and CVOTs across all studies combining primary and secondary groups, there was a 27% reduction in HHF hospitalization for heart failure. CV and renal outcomes with SGLT2 inhibitor. EMPA showed consistent reduction in all CV and renal outcomes. Here it is comparison between EMPA-REG, CANVAS for canagliflozin and declare TIMI for DAPA. You can see this cardiovascular death benefit was only with EMPA. 3-point MES was with EMPA and CANVAS, but it was not with declare. Declare TIMI for dapagliflozin. However, hospitalization for heart failure and decrease in renal outcomes, they were consistent finding. There were robust data in all the trials. Remogliflozin is the molecule which was used on the front of economy, but unfortunately, it doesn't have much of CVOT trials. So empagliflozin heart failure clinical development program, EMPEROR studies are pivotal trials for hard clinical outcome, particularly in cases of heart failure with reduced ejection fraction, where left ventricular ejection fraction is less than, equal to or less than 40%. Long-term renal effects of EMPA for renal outcomes shows the post hoc analysis in a subgroup of patients with prevalent kidney disease, where eGFR was 59 ml per meter from EMPA-REG trial. Empagliflozin was associated with slower progression of kidney disease, lower rates of clinically relevant renal events than was placebo when added to standard care. Empagliflozin was associated with slower progression of kidney disease and lower rates of clinically relevant renal events. Effect of EMPA on the primary composite cardiorenal outcome in EMPA-REG outcome trial showed consistent effects observed for renal composite outcome in credence-like population in EMPA-REG trial. So this is comparison of renal outcomes with SGLT2 inhibitors, credence for CANA, DAPA CKD for DAPA, and EMPA kidney for empagliflozin. Population, however, in credence was only diabetic patients with CKD, whereas in DAPA CKD and EMPA CKD, chronic kidney disease was there with both diabetes and non-diabetic population. And the good effects were consistent with all the three trials. Linagliptin has the broadest clinical evidence of efficacy and safety in DPP-4 class. From this graph, you can see that saxagliptin is safe in cases of patients with high CV risk, but as far as the high kidney risk is concerned, it is uncertain. And in heart failure, definitely it is a green. It is not green signal. It is a red signal. And even ADA has put a warning that there is 27% more risk of hospitalization for heart failure as compared to other gliptins. Tenligliptin, robust data for heart failure and high-risk kidney is lacking, and there is safety signal is red regarding high CV risk because it increases the QTC interval time. Sitagliptin is a good molecule being used in market for some time, for quite some time, having a good safety record. It has got robust data in cases of high CV risk and heart failure. But as far as the kidney risk is concerned, it is uncertain. And in the cases of CKD, it is advisable that the dose should be adjusted accordingly. And linagliptin stands out as one molecule which is friendly with high CV risk, heart failure, and high kidney risk. So this is a feather in the cap of Linagliptin. Now, ESC guidelines on diabetes, pre-diabetes, cardiovascular disease developed in collaboration with EASD recommends that SGLT2 inhibitors, DAPA, EMPA, and CANA are associated with lower risk of heart failure hospitalizations in patients with type 2 diabetes mellitus and are recommended. So these three molecules have been recommended. And DPP4 inhibitors, sitagliptin and linagliptin, have a neutral effect on the risk of heart failure hospitalization and may be considered for diabetics with heart failure. And DPP4 inhibitor significantly increased risk of heart failure hospitalization, not recommended in patients with diabetes with heart failure. Alogliptin was associated with non-significant trend towards heart failure hospitalization. Sitagliptin and linagliptin had a neutral effect. Vildagliptin had no significant effect, but led to increase in left ventricular volumes. What are the learnings from the CARMELINA trial? Linagliptin delayed progression to albuminuria by 14%, and there was 15% higher event of urine albumin creatinine ratio reduction by more than 50% for linagliptin. CARMELINA CV and renal outcomes of linagliptin. CAROLINA CV outcome trial of linagliptin, long-term 6-year study. What did they suggest? CARMELINA established long-term CV and kidney safety profile of Lina versus placebo and demonstrated no increased risk of heart failure even in patients at very high heart failure risk. CAROLINA confirmed long-term safety profile of Lina relative to glimepiride in patients with early type 2 diabetes and increased CV risk in longest DPP4 CVOT trial till date. All the similar glycemic levels, the risk of hypoglycemia was significantly lower with linagliptin compared with glimepiride. CAROLINA and CARMELINA constitute a comprehensive CV outcome trial program demonstrating the long-term safety profile of linagliptin in a broad range of patients. So cardiovascular and renal outcome trials with SGLT2 and DPP4 inhibitor combination, EMPA and Lina appears to have a comprehensive, robust data of CV benefit along with favorable safety profiles. If you compare this EMPA-Lina combination with DAPA, Saxa, and ER2 sitagliptin, this combination of empagliflozin and linagliptin scores over other combination because only empagliflozin is the molecule of the as compared to DAPA and ER2, which is friendly with 3-point which is significantly lowers 3-point MACE, cardiovascular death, HHF, and renal factors. And linagliptin is friendly with 3-point MACE, CV death, heart HHF, and renal factors. DAPA has got good effect on HHF and renal, but as far as the 3-point MACE and CV death is there, it lags behind EMPA. Saxagliptin has got issues with heart failure. And here, sitagliptin has got the questionable renal benefits. Robust data is lacking in that favor. So benefits of EMPA-Lina in patients in fixed dose combination. This is very important. And last but one slide maybe. This is the take home message. What benefit we derive when we combine two good molecules like EMPA and Lina. Number one, there is robust glycosylated hemoglobin reduction with low hypoglycemic reduction risk. Two molecules together, but still chances of hypoglycemia are very low. 2 to 4 folds higher odds of patients reaching the goal glycosylated hemoglobin compared to individual agents. So higher goal achievement is possible and earlier achievement is possible. With durable efficacy, Proven cardiovascular and heart failure evidence with EMPA-Lina combination. Proven renal evidence with EMPA-REG. Weight loss and low risk of genital tract infection. Genital tract infection, which we are so scared when we are using SGLT2 inhibitor. We are very particular about that. And all these benefits with convenience of once day dosing. So friends, with multiple pathophysiological defects and multiple complications, we have got a disease, type 2 diabetes mellitus, where the cost of treatment of diabetes may seem to be expensive, but cost of treating complications is too many. And so we must achieve early control, and durable efficacy should be there, complications should be less. And here, this combination of EMPA and Lina, that is course over. Thank you.
Box.
Hello.
From Dr. Amit Kumar. Can we use this combination in chronic liver cirrhosis patients?
Can we use this combination in chronic liver cirrhosis patient? In the earlier part, when complications are not present, we have to be very particular about this combination, because liver cirrhosis can be associated with portal hypertension. The patient may have fluid and electrolyte combination. So there are certain issues related with it, particularly in the later part. And the drug for emergency, drug for when certain issues are there, is still insulin. But in the uncomplicated liver cirrhosis, they may be judiciously used, keeping an eye on different parameters. But not later on, when fluid and electrolyte imbalance comes into the picture, because hypokalemia is supposed to precipitate the hepatic coma. So this combination, particularly SGLT2, may not be very much ideal in chronic liver cirrhosis patient.
Sir, second question from Dr. Rahul Kumar. Sir, both dapagliflozin and vildagliptin is available at affordable price due to patent off. Can we use separately both molecule and get the same result?
Yes, it is possible to get the results almost similar. As we have already discussed in the slide, we'll discuss DAPA versus EMPA and VILDA versus Lina. As far as the DAPA is concerned, it has got the equally competent data, equally robust data in favor of reducing hospitalization for heart failure and the renal benefits. But as far as the CVD death is concerned, empagliflozin is course over. And even in the mess, reducing the mess, EMPA has got the slight advantage. So empagliflozin will be more preferable over dapagliflozin. And vildagliptin is a good molecule, no doubt. But again, its issues in this kidney, the robust data are lacking as compared to linagliptin. Linagliptin is one molecule which doesn't have the issue. And with the progression of the CKD, you did not reduce the dose. So almost DAPA and VILDA will have the same effect, but these benefits will be lacking. So if the price is not the issue, and then EMPA and Linagliptin, just on the merit basis, is definitely a better combination.
Sir, one more question from Dr. Amit Kumar. Which is better, DAPA or EMPA?
It is very difficult to tell at this stage, but so far, whatever information has come from this EMPA-REG trial and EMPA-REG trial, and for DAPA, we have got declared TIMI and DAPA-HF trial. As of now, the impact of DAPA on MES is less consistent as compared to EMPA, is less prominent. And as far as the cardiovascular defect is concerned, disease death is concerned, EMPA is the only molecule amongst gliflozins which has got a considerable impact. So EMPA will be a preferable molecule. DAPA is very good molecule. In fact, it is dapagliflozin which started DAPA-HF molecule, and then EMPA followed on close on the heels with EMPA-REG trial. And it was the DAPA which first introduced the concept that this can be used in the treatment for reducing the risk of hospitalization for heart failure, not only in the diabetic patient but also in non-diabetic patient. But as far as this trial is concerned, this EMPA has got benefit in the cardiovascular death reduction. Having said that, we have to know, as I have shown in one of the slides, not that slide was not shown, the demography of EMPA-REG trial and declared TIMI trial. In cases of EMPA-REG trial, the total population of the patient, they were having atherosclerotic cardiovascular disease or high risk associated with it. But in DAPA, it was the mixed population. So proper analysis of demography is very essential to conclude on that. But it appears that EMPA has got an advantage in reducing the cardiovascular death. And even US FDA recognizes that. So EMPA may be the better molecule right at the moment.
Sir, that was the last question. So, with your permission, can we conclude the session, or should we wait 1 more minute for more questions?
Now my talk is over. If any fresh question is there, then I'm ready to take that.
No, sir. Any fresh question is not there. That was the last question. So, sir, with your permission, can we conclude the session?
Yes, why not?
Thank you, sir. Thank you for your insightful and educative talk. And thank you, dear delegates, for joining today. Thank you. We are ending this session now. Thank you.